Hi, I'm Scott, and I'm now kind of stuck pondering how my brain's changed in the last hour, and I'm worried it's not a pretty picture. So my talk hopefully will illustrate some of the challenges that the mental health community has had in trying to come up with rules or guidelines for diagnosing mental disorders. But of course, it's about zombies, right? I mean, that's what we're here for. And we've heard a lot about the different features that zombies have had tonight, but I want to share with you some stuff from my own research, because I've spent decades hitting the movie theaters, spending time with my friends Netflix and Hulu, and before that, keeping Blockbuster in business for a while anyway. All my spare time, by the way, because as surprising as it is, in my field, it's really difficult to get grant funding to do this kind of work. But nonetheless, I've persisted, and I found that the picture of what a zombie is, pardon the expression, really messy. As we've heard before, there's a lot of different types of zombies. Sometimes they're depicted as undead, reanimated corpses. Other times, they're just angry people with the flu. Sometimes they're cannibalistic, but other times they don't seem to care about that, and they're just aggressive jerks. Even the cannibalistic ones seem to differ from each other. Some of them, are, as we've heard, are really focused on the brain. Others are less picky eaters. Those who are cannibalistic, though, tend to be pretty obsessed with consuming, whether it be brains or whatever they might have on their minds. As we've seen, movement can be a little bit different. Back in the good old days, they were always slow and lumbering and relatively easy to get away from if there aren't many of them. Nowadays, they tend to be a bit more sprinty. As we've seen, they don't have a lot to say. Their thinking seems to be pretty restricted. They don't have a huge emotional range. And perhaps, well, I mean, a lot of this is troubling, but in combination with some of this other stuff, what's really troubling is they tend to be untiring and relentless. Now, this is a pretty diverse picture. There's clearly more than one way to be a zombie. Oh, good heavens. I wonder what symptom that would be. So put this hand behind my back for the rest of the talk. Regardless of what the pattern is, I think most of us would agree that this is behavior we'd want to keep away from, at least arm's length, at least the zombie's arm's length away from. We'd agree that this is pretty rare, at least for now. Just watch out, people. And I don't get out as much as I used to, but from what I can tell, still this is stuff that deviates from social norms, right? Okay. A lot of these things, so deviating from social norms, being rare, behavior that causes problems, these are things that the average layperson often associates when you ask them with mental disorders. But is that all there is to a mental disorder? Are even these things necessary for mental disorder? And regardless, can zombie-ism be a mental disorder? And for that, I suggest we hit the books. And in particular, one book, the DSM-5, which is the Diagnostic and Statistical Manual for Mental Disorders, 5th edition. It's produced by the American Psychiatric Association. And it's a book that contains the rules for diagnosing all of the mental disorders that are officially recognized by the psychiatric community in the United States and Canada. And it's also used frequently for research throughout the world. So great, we got a set of rules for existing mental disorders, but does this help us in understanding what a mental disorder is, and could zombies have a mental disorder? Well, fortunately, the DSM provides an imperfect but relatively usable working definition of mental disorder. It's pretty long, pretty big, so I'll just walk you through it. The DSM says that a mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental function. Mental disorders are usually associated with significant distress or disability in social, occupational, or important activities. That sounds like zombies might have that covered. An expectable or culturally approved response to a common stressor or loss, such as the death of a loved one, is not a mental disorder. Socially deviant behavior, e.g., political, religious, or sexual, and conflicts that are primarily between the individual and society are not mental disorders unless deviance or conflict results from a disorder in the individual as described above. And I'm going to pause to take a breath. Thank you. So let's unpack some of these things, some of the more important active ingredients of this definition. So syndrome. By syndrome, what we're talking about is a pattern of problems that tend to occur together. In particular, we want our syndromes to show some degree of consistency within a person across time and to some extent across people. Clinically significant came up, and by that we mean the problems a person's having are severe enough that they warrant attention by a mental health professional. Distress means that the problems are causing significant emotional suffering for the individual who has them. And disability is referring to significant impairment at work, school, or in some other important aspect of social functioning. Now, explicitly, if something is an expectable and culturally approved response to an event, it's not a mental disorder. We all are born into cultures. We all grow up in one or more cultures, and cultures differ from each other in terms of how they handle certain situations. And if a pattern is the expected way of dealing with a situation within your culture or one of your cultures, that cannot be a mental disorder. And similarly, we differ from each other within a culture, and just being different, even if it's causing conflict with authority, is not in and of itself a mental disorder. Okay? We don't want to pathologize just being different. So ideally, when we're coming up with rules for diagnosing something like zombieism, we base them on a solid theory of the etiology of a disorder, such as what we've seen about the neurobiology of zombies. Etiology is just a fancy way of saying the causes of the disorder. Okay? Now, I will refer back to my copious amounts of study and research on zombies. And even though we do have some good clues, as was alluded to previously, we still really don't know what's going on with causes of zombieism. I mean, I've seen a lot of reports of different, pretty well documented and supported hypotheses. So, for example, strange radiation off of a crashed space probe, that's been put out there quite convincingly. Virus we've already talked about. A curse or ritual. Reanimation gas. I've even heard of tainted energy drink possibly being the cause of zombieism. And then there's one that comes from the theatrical poster for George A. Romero's 1978 classic, Dawn of the Dead. It said, "When there's no more room in hell, the dead will walk the earth." Which, frankly, I'm not buying, because an organization of those resources could at least put together an annex or like a portable classroom or something if they're pinched for space, I would think. And I've added one more here, which, frankly, I've never heard in connection with zombies, but academics nowadays are all the time blaming things on it. So I figured just for good measure, I'd include the social media. Just to be safe. Now, The state we're in with most of the disorders in the DSM-5 is kind of similar to where we are with zombies. We have some really good research that suggests that we understand really important pieces of the puzzle, but the picture on etiology is complex and it's not entirely clear what's causing the disorder. This is unfortunate because we do want to base our diagnoses, if at all possible, on the etiology, because if we understand the causes and that leads us to reliable diagnoses, those diagnoses might lead to treatments that are more closely related to ameliorating those causes. Okay? So what do we do if we're trying to come up with diagnostic rules and we don't have a clear understanding of etiology? We're actually, well, when I say we, it's not really me, but in the 17th century, Western medicine was in this situation. And there was a British physician named Thomas Sydenham who said that until we get better scientific instruments and we are able to use those to create better theories of what's causing medical conditions, we should base our rules for diagnosis on what he called clinical phenomena. And those are things that can just be assessed in an interview in the physician or healthcare provider's clinic. And that's not a zombie, by the way. That's Dr. Sydenham. Okay. So what are these clinical phenomena? Well, one that Sydenham said we need to pay attention to are symptoms. Those are things that people can verbally report of subjective complaints they're having, like, doctor, I don't know what's going on, but for the last week, all I've been able to think about is eating brains. That would be an example of a symptom. Also signs. These are things that we can objectively observe, like sort of the unusual movement that we see with slumbering, bumbling zombies. So objective things observable to others. And then we've got syndromes, which are these patterns of signs and symptoms that tend to co-occur together. And Sydenham said we need to observe the clinical phenomenon and see what signs and symptoms cohere together in the syndromes. And when coming up with our rules, he said we had to come up with two types of criteria. One type are what we call inclusion criteria. That's a list of all the things an individual has to have in order to say they have the disorder. But we know, any of us who have had a headache and gastrointestinal upset, that different conditions overlap in their symptoms. It could be you've got a virus, could be you've eaten something maybe you shouldn't have, could be you drank something you shouldn't have, or maybe more than you should have of something. Right? So syndromes can overlap in their symptoms. And this is true of psychiatric disorders as well. There are a number of disorders in the DSM where hallucinations can be an indicator, or where severely depressed mood can be at play. So Sydenham said, in order to distinguish syndromes from each other and to distinguish disorders from even non-disordered normal experiences, if there's overlap between a syndrome and normality or other conditions, we need to also identify exclusion criteria that help us distinguish disorders from each other. And so exclusion criteria are all the things that you must not have, that must not be present to say that you have disorder X instead of disorder Y. Okay? So currently, the DSM is pretty much structured based on the Sydenham approach. It's syndromes of signs and symptoms that are specified in terms of inclusion and exclusion criteria. So in a DSM-type diagnosis, the people who end up being diagnosed with the disorder are all the people who have the inclusion criteria and don't have any of the exclusion criteria. Now, there's some other issues that we need to deal with a messy disorder like zombie-ism. How do we establish the pattern? The DSM has a few tricks up its sleeve for that. It often requires that signs or symptoms be frequent in occurrence. They happen a lot. Or they occur for a specified duration of time, or they are pervasive and they pop up in a lot of different aspects of a person's life. We still have zombies. There's a lot of diversity in the kinds of symptoms and signs that can be present. So how do we account for that? This is also the case with a lot of mental disorders. There are some in the DSM where you could have, there's one in particular I'm thinking of, you could have 5 different people with the same diagnosis and none of them share the same signs and symptoms because there's that much diversity in presentation. How do you deal with that? The DSM uses a trick called polythetic criteria to address this. Polythetic criteria is a list of different signs or symptoms, different inclusion criteria, if you will, not all of which have to be present to say that somebody's got disorder. You just need at least a minimum amount. Okay? And this is an approach to dealing with diversity in presentation. So what might, again, I know this is a busy slide, lot on it, but what might a diagnosis in the DSM-5 of zombieism look like? This is my attempt, speaking in DSMEs, of how this might look. So we have criterion A, chronic or recurrent eating of living flesh, organs, or extreme purposeless violence towards others. Criterion B, a polythetic criterion. At least 3 of the following occurring most of the day, nearly every day, to establish that it's pervasive during the episode, and the list includes 6 possible things. You don't need all 6, you just need 3. You don't need any 3 in particular, it could be any of the 3. And the 3 include unusual movement as indicated by lumbering, slow gait, and movements, or accelerated and agitated movement. Untiring, relentless pursuit of victims, mutism or severely limited speech, great deal of time spent with recurrent intrusive thoughts, images, or impulses regarding eating brains. Limited cognitive ability is indicated by reduced planning or problem-solving ability. And last on the list, severely limited affect or emotional experience. Criterion C, duration must be at least 1 week. It's got to be an extended period of time. D, must result in clinically significant distress or impairment in an important area of functioning, which I think most of us could see that this pattern probably would lead to. And lastly, must not be attributable to the physiological effects of a substance, like a drug of abuse or medication, like crocodile. Any of you hear of crocodile, the Russian zombie drug? Okay. Another medical condition, like Ebola or Kuru, or be better accounted for by vampirism, which is another syndrome which overlaps quite a bit with zombieism, but is distinct, right? And that's an approach the DSM does a lot. So not accountable for, better accounted for by disorder X. So this qualifies as a mental disorder because a lot of the core problems here are covering the bases, the trifecta of what are considered mental disorder symptoms. Impairments in behavior, it's the stuff in red, like the recurrent noshing on things you shouldn't nosh, unusual movement, pursuit of victims. Some of them are cognitive, as was alluded to before. The mutism, the impulse, the sort of obsessions about eating brains, the limited cognitive ability, and we also have limited affective experience in here as well. And of course, A through D are all inclusion criteria. E is an example of an exclusion criterion in order to help us separate zombieism from other conditions. Now, I've got a few unanswered questions to leave you with to ponder about mental disorder diagnoses and these rules. Okay? First one is, can a mental disorder still be a mental disorder even if we thoroughly understand its biological underpinnings? In other words, where do we end up with the boundary between mental disorders, psychiatric disorders, and neurological conditions? Can a disorder be both? If we're talking about a supernatural cause, can zombieism still be a mental disorder, or is it just a curse? Impairment and distress. At what point, and can we ever make other people's problems that are the consequence of somebody's behavior a symptom for the person with the behavior? Okay. When we think about culturally normative, is there a point where something that isn't a culturally expected response currently could become so frequent and so normative that it no longer qualifies as a mental disorder? And there are a number of symptoms that are on an increase in terms of how common they are in our population, anxiety being one of them. And then lastly, is there a point where any of the benefits that come from having a mental diagnosis, mental disorder diagnosis, such as for treatment or access to services or understanding a condition, is there ever a point where the costs to that to the individual outweigh those benefits? So is there a point where social prejudice or stigma with the label of having a mental disorder diagnosis outweighs any benefit in society? So these are unanswered questions I'm leaving you with to consider, because just like zombies, they will come back. Okay? Thank you very much.